Thank you, Rachel. I'd like to invite all four speakers to come up to the front, and we will start our Q&A panel.
Sorry, as I'm getting settled, I want to remind everyone as you come up to the mic to please state your name and affiliation, especially for those watching. And I see we already have some questions. I was going to start with a general one, if that's okay, and then move into the audience. So this was terrific. Thank you all very much. It's a great overview. I think it set the stage nicely for the day. And I was really struck, I think we all were, with the subnational differences across and within countries. And I just wanted to get a perspective from all of you on where you think we need to put a lot of effort right now. Obviously, more data are needed. We have data in different areas that enables us to go to the
Local level and really understand what's happening. But we also have a need for interventions that will vary dramatically from perhaps a policy perspective or what we do at a programmatic level, depending upon what we're seeing emerge. So I just wanted to get a perspective on how you think we move forward with that. Training leaders who are, able to go in and collect local data, who are able to really unpack what's happening and design better policy and intervention strategies. It's all needed, I know that, but if you had to really talk right now, based on what we know, a direction you would suggest moving in, I'd love your perspective on that. And maybe we could just get a couple thoughts from everyone and then move right to the microphone. Thank you. And Rachel, we can start with you.
Yeah, I'll go right to the programmatic area because from the perspective of double burden, there's some evidence that we have been causing harm in different parts of the world where our historical knowledge base and our paradigms are to address undernutrition, which is, clearly has been a big problem and a very serious problem in many parts of the world for a long time, including in the U.S. Still. But we have, as a result, I think, been very late in realizing the harms caused by the changes that I showed you in the agricultural and food systems and in the environment, as well as the genetics and epigenetics. So we're really behind the 8 ball on addressing the obesity overweight problem, as we've seen from the data that people showed, and understanding the connections there. So programmatically, the nutrition community continues to focus almost entirely on undernutrition in its various forms, primarily stunting, because that's been the most persistent and difficult form of undernutrition to move the arrow on. And we are in danger of just making things worse in a lot of places, especially lacking the sort of more micro level data. If we look at national averages and other averages, then we're going to say to ourselves, oh, well, we really have to keep doing this, when in fact, in many parts of those countries, communities, and households, we're not helping, we may be harming. So I've called for years for us to say, what would we do differently in our programming, in our funding, and in our policy decisions when understanding malnutrition in all its forms? That's the main thing.
Thank you.
Lindsay.
Yeah, I fully agree with that. In the global nutrition world, especially in where I'm working in India, and I'm sure this is true in other regions and countries, but this perception of overweight and obesity being a positive thing is quite pervasive in the nutrition world. I think because the focus has been on undernourishment for so long, and undernourishment continues to be a problem. So you can't, divert all resources to overweight and obesity. But I do think that getting local data, at least at the state level. We're looking at district level estimates now in India, trying to estimate district level overweight and obesity, and seeing even more heterogeneity district to district. So the finer the data, the better, I think, because that's where the programs and policies, like what you've done in Somerville, will happen. So realizing what the problem is on where along the nutrition spectrum, or if it's on both ends of the nutrition spectrum, at the local level will be critical. And this data is relatively straightforward to collect. And India is a great example of that, where the surveys that we work with routinely have 1.5 million people, and they survey 1.5 million people annually. And so it's possible.
Which I think is also a really good point, is the annual aspect of it. We can't look at data from 10 years ago and design programs. It's really the frequent, real time, and the better we can do with that, I think the better we can design. Thank you.
Yeah, with regard to migrant health specifically, I think there's really a need to move beyond the design that's most commonly used to compare the migrants with the host population, because many of those studies show indeed a higher burden in the migrant population, but to really pinpoint what underlying factors are driving this increased risk, we need to look at other designs as well. So it's comparing, looking at the role of national context and looking at the role of migration. And for migrant studies, you often see that explanatory factors often focus on socioeconomic status, or studies that look at when they find that lower rates of a certain health income in the migrants, then they look at explanations as healthy migrant effect, but there's a need to go beyond that and to look really at also genetic, epigenetic, and other underlying factors explaining the risk. So
absolutely.
Design is a different way of looking at it, and to look more at underlying factors driving.
And I would just add, supplementing when possible with qualitative data. I know I've learned a tremendous amount, going to a specific population and really spending the time trying to understand what's going on, coupled with the environmental context, which, of course, as you pointed out, can impact someone very differently depending on their genetic profile.
And today, due to time, but we also collected qualitative data in the RODEM study, where we did focus groups with those affected by overweight and obesity and those with diabetes, also what they thought the causes were of diabetes and overweight, and see the discrepancies, but what we know are the causes. So, yeah, this, thank you. Indeed.
Right. So I guess sort of addressing from the prevention point of view, I think adoption of the lower BMI cut points for Asian populations, say in the US and other high-income countries, into screening programs could be an important move for prevention. In the data I showed, diabetes, for example, and other metabolic risk factors develop in Asian populations at lower BMI cut points. So to really try to make an impact on preventing metabolic complications and diabetes, as well as the sequelae related to diabetes, it would be important to try to intervene earlier on. So using these lower BMI cut points in screening programs, I think, would be important. And then an area where, and I mentioned this, where we need more research is really looking at that question among children. There's some evidence that children have higher percent body fat at lower, Asian children have higher percent lower body fat at lower BMIs compared to white populations, but again, we need more data because that could be an important step in preventing complications due to adiposity in childhood and adolescence.
Thank you. Okay, we'll go straight to the mic. Bill?
Roundtable on Obesity Solutions. Thank you all. This was a really, this worked exactly as we had planned on the planning committee. So I have a question for Dr. Malik and a question for Dr. Meeks. For Vasanti, if you adjusted the prevalence of obesity in Asians for lower cut points in the United States, how would the prevalence compare to the general population? And for Dr. Meeks, I thought your epigenetic data were fascinating, and I wondered if the epigenetic changes were the same for the three European countries. In other words, are the epigenetic changes in Germany different from those that you might see in London?
Right. So if we, I think, were you asking if we employ or if we use the lower cut points, we would see a higher prevalence of obesity as well as of diabetes.
Right. How would it compare? Has that been done?
I don't know if that's been done. I haven't come across that, but I don't know if Lynn.
Yeah, I think that Will Shue has done those calculations for their recent ADA statement. The ADA has now adopted the lower cut point for screening for diabetes as of last year. And I honestly can't remember the numbers off the top of my head, but I believe as part of that effort for ADA, he did do that.
So with regards to epigenetics, we haven't looked at the epigenetic differences between the European context, also because we have epigenetics data only for a subset of the rodent samples, so those sample sizes were too small. But we have compared epigenetic profile between Canadian migrants in Europe with urban Ghana and rural Ghana, and we saw across the genome many loci differing between those different sites. This shows that there's a wide, because of all those environmental factors differing between those sites, they're triggering immense epigenetic changes, but we have to zoom into and look more into specific areas. But clearly shows a very large role of environment on epigenetics, and that's likely also increasing disease risk in European settings.
Thank you.
Thank you so much. I'm Sam Stebbins. I'm a public health physician in D.C. and also this year a Robert Wood Johnson Health Policy Fellow. So thank you all. This is a question for anyone. It's based on Dr. Nugent's one of the slides about sort of solutions that have kind of affect positively both sides of the equation. Breastfeeding was high up there, but down at the bottom was about sort of farming and food distribution practices, and that seems like the core issue across nearly every country. So I'm wondering if there's any countries that are doing a particularly good job at actually trying to have a healthy food creation and distribution system that we could learn from.
Yeah, it's a great question. There's a whole field of study called nutrition-sensitive agriculture, and they've been trying to identify what works for changing agriculture and food systems without much success in terms of sort of our research outcomes, because agriculture programs and studies are not designed to measure nutrition outcomes, let alone health outcomes. So we don't have strong evidence of causal connections. There's reasonably good evidence, or there's good associations that we can see, and there's just plain old logic that tells us things about what the food system is producing in terms of getting healthier food to people, and a lot of that work is in value chains, as they call them. Can we identify value chain processes that can get healthier food to people? So that would involve sort of less wastage along the way, better transportation, refrigeration, and so on. Every point of the way along that value chain, you can identify some ways that you think are probably going to be able to deliver healthier food to people, and likely then we would think to have better outcomes on nutrition and on health. But as I said at the start, we don't have very strong evidence of those causal relationships. Now, as to countries where we have some good examples, I mentioned earlier that Chile is one of the places where they have been quite aggressive in looking at food policy, and other countries as well, primarily pointing towards changes in marketing and advertising, particularly to children, that can be very helpful. That's not so much food system, it's sort of way downstream. More upstream, I guess the strongest pitch I would make is clearly to take a look at policies, particularly subsidy and tax and trade policies, the economic policies that are going to provide the incentives to farmers and everybody else in the food system, and figure out where you're doing harm and try to stop that harm. Case in point, in the U.S. food subsidies, the commodity programs that have way over subsidized corn and other large grains that lead to high fructose corn syrup being in everything we eat and so on. So, and the U.S. and Europe are not the only ones that have done that. That's sort of historically, we have a lot of information about our agricultural policies and what they have done in terms of the results that we get. But now there are developing countries implementing the same kinds of subsidy policies to protect their farmers, but without regard to what the results are in terms of the food production and nutrition. So it's, again, sort of a plea to have a more cohesive, integrative way of thinking about these things, because it's all connected.
Yeah. I would just add to that the sort of food systems work where people are doing more sophisticated modeling and looking at feedback loops in between sort of the linear portrayal of this, I think is incredibly important, because it isn't linear, although we could think about it that way, but it certainly changes once it's in the real world and the complexity is at play. So I think there's more and more being done about that. In fact, I know there are some papers coming out, so you can look for those.
And just one note about the low and middle income country context where we've been engaged in some of this work trying to link agriculture and nutrition. It's very different in that context because it's mostly smallholder farmers. So in India, the vast majority of farmers own less than 1 hectare of land. And so the large-scale national policies that we talk about in higher income countries are not as applicable in those contexts where the livelihoods of farmers certainly the livelihoods of farmers are impacted by these policies here. But in these areas where the vast majority of the population are smallholder farmers that are engaged directly in agriculture, I think that the conversations around agriculture policy are much more complicated, and it's not going to be just a one-fix solution like subsidizing fruits and vegetables in those areas. So, and then just one more pitch on the endocrine disruptors. A lot of the work that I've been working on in these contexts around agriculture has been on endocrine disruptors that are linked to obesity as well, and haven't been part of the discussion around improving agriculture and the quality of the food system. So another thing that complicates this situation and the feedback.
Thank you.
Thank you. Question?
Good morning. I'm Michelle Dennison. I'm a dietitian, diabetes educator with the Oklahoma City Indian Clinic in Oklahoma City, and also a Robert Wood Johnson Health Policy Fellow this year. My first question is for Dr. Malik. Can you kind of explain the thought process of still using the BMI indicator when body fat percentage might be more useful, or have you given any thought into transversing into using body fat percentage, given that it's a better indicator for insulin resistance and progression to type 2?
Right, so there's been conversations about that, specifically waist circumference, which would be a measure of abdominal adiposity versus BMI. And the difficulty with using waist circumference is it's more complicated to measure. So you have to get it in the right spot, and it's usually done in triplicate. So for simplicity and ease, BMI is more straightforward to use. But I think waist circumference, if measured properly, would be a better indicator of adiposity. So I would support that. But again, in the field, BMI is easier to use.
Follow-up question?
Yeah, please. That's okay.
The other question is for you in your research in India. Have you looked at any of the gut microbiome associations with development of type 2? Can you expand on that?
Yes, I haven't personally done any of that research. There is a lot of research increasingly, especially on enteropathy and gut microbiome and links to undernutrition, especially stunting, and then future adult risk of overweight and obesity. But it's in the very, very early stages, and I think most of the focus has been on the links to stunting or short stature for age. And not much on adult chronic disease yet, but definitely some interest in that. And just kind of getting back to this question about adiposity, I think I agree. It would be really hard to measure, given our current tools for percent body fat, to measure adiposity in 1.5 million people. And so there's this balance between getting the local microdata that we all would love to have, to guide policy or to evaluate policies, and then the accuracy of the measurement. And this is a constant thing that we talk about. And measuring waist circumference is extremely difficult to do well. Same thing with calipers. I mean, they're great tools and can be done in the field, but it takes a lot of time.
Ted Kyle with the Roundtable. A lot of good discussion of the composition and quality of the food supply, but I'm wondering if the panel could comment on a global perspective or a transnational perspective on the culture of food and its consumption and preparation and nourishment.
An example of what we've seen among Ghanaian population. In Ghana, for a long time, there was a national campaign to advocate palm oil, because palm oil is rich in vitamin A, and in Ghana, there was a high rate of vitamin A deficiency. Ghanaian migrants who arrived in Europe still remembered that campaign and were used to using palm oil. But now Ghanaians in Amsterdam and Europe still consume quite a lot of palm oil, which is also very high in saturated fat, while vitamin A deficiency is very uncommon in Europe. So what we see is that they take food traditions with them when they migrate, but that they may not be suited for the context anymore.
I think another point that would be important, I think this really represents an area where we need to do more research, so the relationship between culture and food and dietary intake and how we can intervene on that, because I think, we certainly know the relationship between diet quality and various health outcomes, but we don't really have a good handle on the drivers of food consumption, and culture being one of them. So I think doing more qualitative research and trying to really understand the motivations behind diet choice, including culture, would be very helpful in trying to establish interventions to improve diet quality.
I'm not an expert in this area at all, but I have a couple of anecdotes that suggest something to me. I'd be very interested in your reactions. We've been doing work on non-communicable disease prevention and in a number of countries, looking at the array of policy and clinical interventions that can be done, and working with ministries of health to help them make decisions about it, to prioritize based on costs and epidemiology and benefits and so on. One example is in Jamaica, where there's very high obesity and high diabetes rates, and we were told that their traditional foods like codfish, ackee, and codfish are saltfish. Cod, but saltfish, are something that people won't give up. I mean, there's a sense that, when you come in and you say, well, you really need to make these changes in policies or programs to help people eat in a more healthy way, there's a sense that it's kind of either or, that that someone's going to take away something that's highly valued in the culture, and there's sort of an immediate resistance to it. Well, at the same time, what you observe and what people are well aware of is that there's high fast food consumption. What people are consuming is actually very different than the traditional foods. And I saw the same thing in Indonesia, where rice is a major staple there, and rice is still very, very important in the diet, and not necessarily the best thing for people to be eating large amounts of. But what they eat much more of is very high oil, salt, sugar content fast food and junk food. I mean, if you look at sort of what is available in Indonesia at retail, it's sort of shocking, because it's not traditional food at all. So this I don't understand, because I'm not a sociologist, but I think this is where we need the qualitative research, is to understand, people have values-driven attachments to things that are very strong, but belied by their behavior. And as an economist, I kind of think that a lot of the issue is that it's cheaper to buy that fast food, and we've got lots of evidence of that. That's not to say that's the only thing driving behaviors, but that's a big change that has taken place in a lot of these places that we see.
Thank you. We'll take one more brief question in response. Thank you.
Thank you very much. Carlos Williams. I'm a physician. This year's Robert Wood Johnson Fellow as well, with a former U.S. Health Attaché in the South Pacific. And so one of our major issues that we had was working with countries to develop policies that would inhibit more developed nations from importing high processed fat foods. We know things like mud flaps is something that you learn very quickly. And a large part of what you just said was going to answer my question. I want to know, is there a global effort now? We worked in WIPRO to help the Pacific Island countries, but is there a global effort to work with countries to help them prevent more developed imports of poor quality foods? Because we saw a lot of the indigenous population, when you look at the studies, their indices were much lower when they were only eating traditional foods. But now that they have a lot of imported foods, the indices have gone off the chart. Diabetes, hypertension, and other things are now significantly higher.
Well, I mean, as you know, probably it's the WTO and our trade regime that has dictated in a way that countries have. They may not put up barriers to imports that are not also applied to domestic companies, as it were, or domestic sales. So there's presumed to be an equivalency, but in countries like the South Pacific countries where there is capacity to grow certain things but not to produce other things, it has a big effect. All in all, it generally has trade has a generally very positive effect on nutrition, and when you look across many countries, you can see over years and decades big improvements in nutrition that you can attribute to trade in lots of places, but that's certainly not always the case. I mean, Chile, for example, a huge producer of citrus fruits, and puts a lot of it into, in fact, the Chilean government subsidized processing of fruit into fruit juices and other processed fruit that is then with added sugars and sweeteners. So, and most of that is exported. So it's exporting what would be healthy food, but in a less healthy form. And that's driven by trade desires. So it's very complicated, as I'm sure you know. We did a little study in Tuvalu, just you might be interested recently, because they have such a high rate of chronic kidney disease. And the problem is that they don't have in place good preventive mechanisms, so people reach sort of advanced stage of disease before they are able to do something about it in the health system.
Thank you.
Good. So I have a thank you and an announcement. So first, I want to thank our amazing panel. This was really terrific. I know everyone enjoyed it and now is set for the rest of the day to dive into this global issue. So thank you all very much.